Welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for our presenter, please hold until the Q&A segment at the end of the talk. If you're attending virtually and have a question, please enter it into the Q&A section. Also, a link to the event survey will be shared at the end of the program. It is my pleasure now to introduce our speaker, Dr. Rayan Salih. Dr. Salih is a third-year internal medicine resident at Northeast Georgia Medical Center with a passion for cardiology research and education. She has shared her work at national meetings and is committed to improving outcomes in heart and vascular health. Please join me in welcoming Dr. Salih.
Hello, everyone. I'm going to talk today about barostims and their role in heart failure. I have no financial disclosures. And so I'm going to start my talk by talking about pathophysiology of heart failure. So basically, when you have heart failure, your heart is weak for any cause, right? So you have reduced cardiac output, and as a result, the stretch to the carotid arteries is less. And that causes less signals to from the baroreceptors. As a result, the brain thinks that we are maybe dehydrated or having an acute hemorrhage. So it freaks out, and then it increases the sympathetic activities and decreases the parasympathetic activities. And that leads to RAS activation and the heart failure symptoms. So initially, this helps a lot with the cardiac output and everything, but once it's there for a long time, it causes cardiac remodeling and it causes all the symptoms of heart failure. So GDMT role is basically at the neurohormonal area down here. So it blocks the renin, angiotensin, and all of that, and the beta blocker obviously blocks the sympathetic system, and they're doing a great job in reducing mortality and morbidity, as we know from a lot of clinical trials. And here we can see that as the heart failure progresses, the quality of life of the patients goes down. So here in the early stages, we see like stage 1, stage 2 heart failure patients. We diagnose them. We start them on all GDMT, try to see if they qualify for any device therapy, and we're doing a good job here. At the end of the spectrum, we have the advanced heart failure patients who unfortunately don't have much to offer other than VATS and heart transplant, basically. In the middle here, after we give GDMT devices and everything, some patients would still have symptoms, especially functional symptoms. They can't play with their kids, they can't walk to their mailbox. So these patients here, what do we do for them? So let's see. As far as the functional exercise capacity here, GDMT doesn't do much benefit here. You can argue for MRA, it does 7%, but other than that, the CRT over there, class 1 indication for CRT is left bundle branch block and EF less than 35%, specifically QRS duration more than 150. So these class 1 CRT patients benefit the most as far as functional capacity with 19% improvement in that. But class 2A CRT does not really benefit much. It's 99%, just like close to the MRA. And what's interesting is from 100% of the population, only 30% would be qualified for CRT to get this functional improvement. So from these 30%, only 14% are class 1 indication, meaning these are the only percentage, the 14% is the only ones who are gonna benefit the most from as far as exercise capacity. So heart failure patients Most of them, again, they have functional and mobility problems. Most of them have pains, and they also have anxiety and depression as a result of all these symptoms. And if you really ask them what is better for them to have better quality of life, get better functionally, be able to do their daily living activities, or live longer, 65% would choose to have better quality of life and a little bit shorter life. Obviously, with better quality of life, not like for. So these patients, they would have would benefit from small devices like Barostim. So what does Barostim do to patients? So it works here at this step here. So remember earlier I said with less stretch, we have less signaling from the baroreceptors. So once we put these small devices here, they send electrical currency and activates the baroreceptors, and that leads to increased signals from them, which calms down the brain and tells it, we're okay, we're not dehydrated or anything, so sympathetic drive goes down, and all the RAS cascade gets interrupted. So this is actually a picture of me and Sana attending Dr. Raj's talk about Barostim. And I don't know if you can see, the device is really, really small and tiny. So the elements of the system is this implantable pulse generator. They put it under the skin in a pocket, and then it gets connected to this carotid sinus lead. It's a really, really thin and tiny lead that gets placed by CTS surgery on the top of the carotid artery externally at the adventitia of the artery. So there is no intravascular component of the system, so very, very much less infection rate, or lower infection rate, I should say. So they tunnel that lead under the skin and connect it to the generator in the pocket, and then they check the system with a wireless programmer. And they start the signaling, and they go up and titrate the signaling every 2 to 4 weeks at a time. So after you're done with the surgery, it's a small procedure. After you're done, you stay under observation for 4 hours, because some patients tend to have low blood pressure in the first couple of hours after implantation. So once you're done, they go up and titrate periodically, as I said. So what's the evidence behind Barostim? We have this big trial here. It's called HFrEF trial that was published in 2019. It's a randomized controlled trial that had a total of 323 patients. They had ejection fraction of 35% or less and NT-proBNP of less than 1,600. And obviously, they're not qualified for class 1 indication of CRT, and they had previous hospitalizations or had proBNP of 400 or more. So they divided these patients into 2 groups, 1-to-1 randomization. One arm is the GDMT medical arm, and the other arm is Barostim plus medical therapy, which is GDMT. They followed these patients initially for 6 months. The primary endpoint was the safety profile of the device. Secondary endpoint was the 6 months symptom improvement, and the third one was the NT-proBNP level. So they found that the device has really high safety profile. It improved patient symptoms at 6 months, and it decreased the NT-proBNP levels at 6 months, and that warranted the device the FDA approval at that time in 2019. So the post-marketing phase of the trial continued after that, and at 2 years, they reconvened again, and they checked the safety and found that the safety was okay. And then they checked the symptom improvement at 6 months, 12 months, and 24 months, and it was also good. And then they checked the cardiovascular death and heart failure hospitalization, and unfortunately that wasn't statistically significant. And mind you, after 2019, we started to have the COVID and all the mortality from the COVID, so that might have been affected the results of the trial. Other than that, they also checked the all-cause death, LVAD, and transplant transitioning after the implantation, and they found that the arm with the Barostim had less mortality, all-cause mortality, and they had less LVAD and transplant transitioning, but the p-value for that wasn't significant. So there is association, but it doesn't necessarily significant. All right, so let's unpack this trial and dive deeper, I guess. So this is here the improvement in 6-minute walk distance over time. The black column here is the Barostim group, the blue one is the control, and the difference is the gray one. So as you can quickly tell that the Barostim arm did really, really well, and the difference is 56 meters. Mind you, the clinically meaningful distance is 25 meters, so that's more than double. And then when you take this and compare it with the big CRT trials, because as we know, CRT is the best right now in the market. So if you compare these two, they actually do better slightly, all right? And the p-value was significant here. And then once we look at the quality of life with Barostim, they use the Minnesota Living with Heart Failure score. It's just like the Kansas City questionnaire, cardiomyopathy questionnaire. Anyways, so here, the lower number means better outcomes, okay? So again, black one is Barostim, blue one is control, and this is the difference. As you can tell, they did better as well, and the clinically meaningful is -5 points. So they did -20 points here at 6 months, and -18 points at 2 years, so that's quite high. And then when you see the domains of the quality of life, you can see the physical domain, emotional, and health, overall health status, they also did well in all of them. And when you take all of this and compare it with the CRT trials, you can see that they did quite similar, if not better. And here we're looking at the NYHA class. Again, consistent, they're getting better at 6 months, 12 months, and 2 years. And when you compare it here, it's right in the middle between these two trials, so it's about the same. And then this is the Kaplan-Meier-Fisher curve for the all-cause mortality and the LVAD transplant patients. We can see the trend here of the higher survival as comparison to the control, but the p-value here is almost significant, a little bit higher than significance. So there is a trend, but it's not necessarily statistically significant. All right, so here is the safety profile behind the Barostim in this trial. So you can see the event rate is only 3.1% with only 1.3% infection rate. And mind you, it's, again, extravascular device, so it has very, very low rates of infection. And other than that, in the trial, they didn't notice any decrease in heart rate or blood pressure. So it doesn't really affect the blood pressure and heart rate that much. They didn't observe that in this trial. Okay, so there is more evidence that Barostim decreases the healthcare utilization in heart failure, and that was highlighted by these two trials, the HFrEF trial. It's not a trial, it's actually a study. So HFrEF study and USC KIC study. They looked at the patient pre-implant and post-implant, 6 months post-implant, and they found that the hospitalization rate is actually lower, as we can see. So there is some evidence behind that, and we just need to do more trials to confirm this observation. All right, going back to this first graph here, now we added the Barostim in the comparison. GDMT, not too good as far as functional status, great at mortality and morbidity. CRT, great, but just class 1 indication, which is only 14%. Barostim, everyone in between, and it's actually as good as CRT. All right, and going back here, who should we give or consider for Barostim is this middle population here. Anyone who was on GDMT, maximally tolerated dose of GDMT, we did the devices and everything, and they're still symptomatic, they still can't do their activities. We have to consider them for Barostim. Obviously, they can't be end stage and in the transplant list and under the process of LVAD. So this sweet spot here is the perfect time to think of Barostim. All right, so what are the indications? I kind of talked about this a little bit. So anyone who is NYHA class 3 or class 2 and class 2 but had recent history of class 3, which is defined as in the last 6 months was class 3. And they were on maximally tolerated GDMT, including the devices. We should think of Barostim in this population. Obviously, they have to have 35% or less of ejection fraction, and their NT-proBNP has to be less than 1,600. And there is actually a reason behind why they chose the 1,600. It wasn't just a random number. So basically, in the original BETA-HFrEF trial, they had 3 groups, 5,000 and above, the NT-proBNP value 5,000 and above, and 1,600 to 5,000, and then less than 1,600. The more than 5,000 people, they didn't meet the primary endpoint, so they were excluded. And then the people between 1,600 and 5,000, they met the endpoint, and they had improvement in, I think they didn't meet the endpoint, but they had improvement in their symptoms. But the people less than 1,600, they met the endpoint, they had improvement in all domains. All right, so what should we consider when we do the Barostim? Who should we consider for Barostim? Sorry for this thing here. So patients who had ICD and they still have exercise limited, they still can't do their daily livings, we can still consider them. So if a patient has CRT or ICD, we can still give them the Barostim. They're just considered as non-responders. All right, so these are my references. I also had a slide about the safety profile again, emphasizing that it's an extremely safe procedure, I should say, and there is no known interaction with other devices like the pacemakers, CRT, as I said, and ICDs. There's also no known interaction with the spinal nerve stimulators or any of that, so it's quite peaceful device, I should say. Some people had some concerns about the vagal side effects, so we tend to avoid implantation in patients who have bradycardia, symptomatic bradycardia. We tend to just avoid doing that. And then, again, as I mentioned earlier, there was no decrease in blood pressure or heart rate noticed in the trial, the BETA-HFrEF trial. And then, again, contraindication. Anyone who is going for this device, we have to do carotid Doppler ultrasound before we decide on the implantation, because if they have their bifurcation up there, we can't do the device, we can't implant it. Or if they have more than 50% stenosis in their carotid arteries bilaterally, we can't do it, because when you stimulate these currents, it might increase the risk for dislodging a clot or something, God forbid. But yeah, So these are the contraindications. And then the questions, I have 2 questions here. So in BETA-HF trial, Barostim therapy in patients with HFrEF was associated with which of the following benefits at 6 months? Do you guys want options or you were following?
Go ahead and send options.
Okay, so reduction in NT-proBNP, improvement in 6-minute walk distance, and improvement of quality of life. Is that correct? That's option number 1. Option number 2, reduction in cardiovascular mortality and heart failure hospitalizations. Option number 3, increase in ejection fraction. And then option number 4 is no significant difference compared to control.
What do we think?
Go ahead.
One, the first option? First option.
Good job.
Yay, good job,
Yay.
everyone.
And then the second question is, which of the following anatomical findings on carotid Doppler would make Barostim implantation contraindicated? I gave you guys easy questions. You guys want options?
Wants to answer?
Bilaterally.
Yeah, like 50% stenosis bilaterally, or if the anatomy is like not compatible.
Good job. And that's it.
Okay, thank you so much. Does anybody have any questions you'd like to ask? Comments? Just raise your hand. Oh, we have a question down here.
Yeah, thank you so much for the presentation. That's an interesting device. No idea it existed. So any studies kind of looking at using this device along with CRT, like CRT doesn't have to fail, just use both and see if it gives a better outcome, or is that just excessive?
I'm not aware of any current trials, but we didn't see any problem with putting this device on CRT patients. As a matter of fact, if a patient has a CRT or ICD and they're still feeling symptoms, it's actually, we should consider these patients for Barostim. So it's quite safe with other devices.
Thank you very much for this topic. It's very interesting. I didn't know about the device. It looks like it's probably the future of heart failure management. Has it started being used like regularly in hospitals, or is still like in the clinical phase trial 3?
That's a
Do
good
we have
question.
it here
So-
at our hospital?
Yeah, so the device was FDA-approved in 2019, as I mentioned earlier. And in our hospital, actually, Dr. Raja is a part of the committee for the device, and we have 25 patients who had the Barostim. And that's the purpose of my grand rounds now. So you guys can refer these type of patients to heart failure specialists so we can get more patients benefit.
I think that's a wrap. Thank you so much. Excellent.
Thank you.